much. Good morning. It's an honor for me to be here. Every time I come to an ASCRS meeting, I'm always filled with happy and warm memories of times I've shared here with Charlie and all our friends from all over the world. I always feel the love and the admirations you have for Charlie. The Charles D. Kelman Innovator Lecture honors the work of individuals whose creativity has advanced the art and the science of ophthalmology. And today's honoree has indeed made significant contribution throughout the course of his career. A better understanding of the optics of the cornea is required for several aspects of intraocular lens surgery, including the accuracy of IOL calculations, visual quality, depth of focus, and IOL toricity. Dr. Douglas Koch is a professor of ophthalmology and holds the Allen, Mosbecker, and Law Chair in Ophthalmology at the Cullen Eye Institute, Baylor College of Medicine in Houston, Texas. His lecture today is titled Corneal Optics for IOL Selection, Cracking the Code. I'm very honored to introduce a good friend, Dr. Koch.
Thanks so much, Anne, and good morning, everyone. I'm so amazed and honored to be here. I've learned so much and admired so much the work of the previous 27 innovators. I'm kind of bowled over still. And it gives me particular pleasure to give a talk that has Charlie Kelman's name on it. He was a friend. I had the great opportunity to work with him on the executive committee of ASCRS. I taught in his course at the Academy, and he taught me so much. And I remember with a special fondness of one day that we were at a meeting in Nice, and there was a day off, and Howard Fine and I and Charlie and Anne and Charlie's son Evan went to see the ruins of Pompeii, and I got to see Charlie in the role of a very loving and devoted father. I think that Charlie would really like this topic. He was all about quality and getting it right, and after all, we still use one of the intraocular lenses that he developed. So my topic for today is corneal optics for IOL selection, cracking the code. This is my financial disclosure. And I want to begin by acknowledging the people with whom I've worked on various aspects of this talk. My partner, Mitch Weichert, who's been just so fabulous in many aspects of this. Liz Yu, as you will see, has contributed a lot to it. My research fellow this year, Richard Jenkins, who's done such a wonderful job. And you'll see his role later in this talk. And my colleague Lee Wong, with whom I've had the incredible luck to work for over 10 years. I couldn't have worked with a finer person or a better scientist, and I'm so lucky to have had this opportunity. So thank you, Lee. So I want to share with you 10 things that I think ophthalmologists need to know about the cornea in order to maximize their IOL outcomes. Number one, for normal eyes, for standard IOLs and current measuring technology and formulas, most devices for measuring corneal power work quite well. They're satisfactory. We have a big range of devices, from the manual keratometer, going from 4 points, to the IOL Master with 6 points, to the LensStar with 24 points of measurement, and then of course topographers. And they all do a great job in a sort of standard situation. But number two, they all measure the anterior corneal curvature, all the devices I mentioned, and most of the ones that we use, and assume that the ratio of the front and the back is constant. Now, that's an interesting assumption because different formulas, different machines, different countries, Germany versus the United States, use a different assumed ratio because it's all been a bit of a guess. And so you just pick a ratio and you stick with it. And we published a paper in conjunction with Cynthia Roberts' group at Ohio State looking at the ratio of the front and the back of different types of cornea, because cornea is using the dual shine fluid device, the Galilei. And you can see that the standardized index of refraction varied in the Gullstrand model eye from 1.3315, a little bit lower than normal eye, even lower in an eye after myopic LASIK. but higher in eyes after hyperopic LASIK. Now these numbers seem small, but these small differences can produce clinically large differences in corneal power that's used for IOL calculations, and this takes on particular importance in eyes that have undergone corneal refractive surgery. Number 3, the cornea has higher order aberrations that vary widely among individuals and change over time. This is our paper looking at the anterior corneal aberrations as a function of age, and you can see the gradual increase in the curve. This is all the higher order aberrations as opposed to spherical aberration, which is around a mean, but you can see the wide variation of plus 0.27 microns, and that in fact is quite constant with age in the human cornea. Now the downside, of course, of higher order aberrations being increased is the potential to reduce image quality. And I say potential because it depends very much upon the mix and the magnitude of the various aberrations. On the other hand, there is an upside, and that is greater depth of focus. And this is a paper that Liz Yu co-authored that's just been published, e-published for AJO, looking at what we calculated to be higher order aberrations over a 4 millimeter zone in normal corneas, corneas after myopic PRK, and corneas after hyperopic LASIK. And you can see that with the increase in higher order aberrations from the refractive surgery, there is indeed greater depth of focus. But I'm struck by the overlap among them. So there's still a lot to learn. We've got some things we're figuring out, but we still have to sort this out more. Now we can use corneal higher order aberrations in optimizing the IOL design for our patients. And modulating spherical aberration is where this comes into play, as many of you know. And if we look at the lenses that are available in the United States in terms of their various ranges of spherical aberration, the amotechnis lens is designed to neutralize that plus 0.27 of the cornea, leaving the eye on average with no spherical aberration, contrasted with the standard spherical IOL that has about 0.18 and will leave the eye with about plus 0.45. And of course, the question we ask is, how important is this? The reason that these lenses with negative spherical aberration got that new technology designation several years ago is because they were demonstrated to improve driving safety. When people drive under adverse conditions with a proper correction, they stop, for example, with a Technis lens 45 feet sooner when they were going 55 miles an hour. And you may think, what's that about? And in fact, that is more advantage than any other safety innovation that has been put in cars in the last 10 years. Well, what about depth of focus? What is spherical aberration in the cornea and in the eye due to depth of focus? And there was a wonderful study published by Rocha and colleagues in ophthalmology in 2007 where they looked at distance-corrected near vision, a randomized study with a lens. Some eyes got spherical lenses, some got positive asphericity lenses and negative asphericity lenses, and you can see that the distance-corrected acuity is a little less than 1 line worse when the spherical aberration was largely reduced. Well, why don't our patients notice much about their spherical aberration? I don't think we hear a lot of, or sense a lot of comments from them about that. It's because in order to get the benefit from it, you have to have a very accurate refraction. And it very much depends on pupil size. And this demonstrates this, I think, quite well, comparing the ocular spherical aberration with the Technis lens and a standard lens. For a 6 millimeter pupil, you can see the difference in dioptric terms is about 0.35 diopters, which could matter in terms of seeing street signs and so on. But with a 4 millimeter pupil, it's less than 1/4 of a diopter. So it may not be as always perceptible if the pupil is small. Well, higher order aberrations of the cornea offer us an opportunity because if we understand them better and how they create depth of focus, we're going to be able to predict the quality of vision and the depth of focus for each of our patients. We're going to be able to match the IOL to the corneal higher order aberrations to achieve the desired optical outcome. And we're going to be able to design new IOLs that have higher order aberrations to maximize the desired optical outcome. And for example, I know that Graham Barrett is working on that very project now. Number 5, with current technology and formulas, higher order aberrations are not used to select the IOL spherical power, the dioptric power in normal eyes. But I think this will change in the future. Progress is being made. But currently, I think that spherical aberration is sort of lost in the noise of the errors and the other measurement variability. Ray tracing holds great promise, and I want to acknowledge the work in this area that Thomas Olson and Jaime Aramberi are doing. And another approach, Warren Hill, is looking at engineering principles. It'll be interesting to see if his approach shows that spherical aberration is important. However, corneal higher order aberrations do play a critical role in calculating IOL power in eyes that have undergone corneal refractive surgery. But we have a long way to go. Why do these higher order aberrations matter? It's because there's greater variability in power over the central zone, and topographic measurements account for this irregularity. And that's why we often use topography in order to do these calculations, because topography in effect incorporates the higher order aberrations by measuring the entire corneal surface over the central zone. And again, I think ray tracing holds great promise in this regard. And in the ASCRS IOL calculator, several of the formulas rely upon corneal topography values that are average values over central zones. But I should point out that there's some excellent formulas that also use just the 6 or points from the IOL master, or the 12 or the 24 from the lens star. So again, we have a way to go to refine all of this. Number 7, measuring posterior corneal power should improve the accuracy of IOL calculations. It makes total sense. If we can measure the entire cornea, we ought to be able to nail the corneal element. And this is going to be especially important in eyes that have undergone refractive surgery. We've had the opportunity to work with the Galilei device, the dual shine fluid combined with a placido, and developed a formula for using these values to calculate IOL power. That's on the ASCRS website. And more recently, we've been working with OCT, specifically the RT-View, which is a Fourier domain OCT system, and a formula that was developed by David Wong's group, Long Tong and David Wong. And we've recently analyzed 14 eyes, it's a small cohort, comparing these to the other formulas that we typically use. On the ASCRS calculator, these are the formulas that rely only on clinical history. This is the mean absolute error. You can see it's really quite high. This is the group of formulas that you need to know the change in manifest refraction, but you only use a fraction of this to calculate it, and you can see the mean absolute error here for these 14 eyes. And then these are the formulas that require no prior data. You don't need to know the previous Ks, refraction. And you can see that the Galilei is certainly matching these others, and I think there's a lot of room for work here. And the early results with the OCT formula are in fact very encouraging. Now, all of these things are works in progress, including these other formulas, as we continue to refine them. Number 8. After 30 plus years of thinking about the cornea, I missed a crucial element. And as usual, my patients taught me the lesson. And they do it every day, don't they? This very thoughtful and probing engineer came to me saying he needed cataract surgery, and he showed this amount of astigmatism, and I said to him, I think you need a toric lens, and I can correct your astigmatism. And he said, well, how does a toric lens work, and how do you know it's accurate? Are your measurements accurate? And I said, you know, I am so good with this lens, I'm going to nail it for you. Notice his refraction has a little less astigmatism. Topography is unremarkable. I implanted a T4, which was certainly adequate to correct most, but not even all, of his measured astigmatism. He wanted an intermediate target. Postoperatively, he said his vision's fuzzy. He has 3/4 of a diopter of against the rule astigmatism. And I flipped his axis by 3/4 of a diopter. I've had fun chatting with him since. This lady, very particular, lovely lady, wants to read. She's used to reading without glasses. You can see her refraction. She's really quite myopic. She's used to reading perfectly without glasses. She had about 1.5 diopters against the rule of astigmatism. And conservatively, you could say put in a T3, more aggressively a T4. Topography is unremarkable. I placed a T4, perfectly aligned. She's undercorrected by a diopter. Another hour of interesting conversation ensued. So I missed it in both of these patients. Concurrently, we had been using the Galilei and really trying to understand more about corneal curvature, looking at total corneal power using ray tracing through the anterior and posterior surfaces. And we looked at consecutive eyes who were candidates for cataract or refractive surgery, all healthy, 715 eyes and 434 patients with a large age range, notice it's 20 to 89. And what we found for the mean astigmatism from front corneal, anterior corneal values is around 1 diopter, but interestingly, the posterior corneal surface had minus 0.3 diopters. So there was posterior corneal astigmatism as high as 1.1. That was rather a revelation to me. And then if we look at the distribution of astigmatism, both on the front and on the back of the cornea, I'm first going to show you what this astigmatism on the anterior corneal surface, and the 60 to 90 degree zone here tells us the with the rule zone, and in this range of 20 to 89, half of the corneas had with the rule astigmatism. By contrast, on the posterior surface, this is the vertical meridian on the posterior surface, 87% were steep along the posterior surface. Well, when you look at the relationship between the front and the back, on the with the rule eyes, the more curvature on the front, the greater the curvature on the back. Interestingly, however, in the posterior surface, there was really no correlation between the magnitude of the curvature of the back and the front. So what's the effect of the posterior cornea being steep vertically? That effect is, because this is a minus lens, it creates net plus power along the horizontal meridian, which means it creates against the rule ocular astigmatism. Now, traditional thinking has it that posterior corneal astigmatism is trivial due to the smaller difference in refractive index between the posterior surface of the cornea and the aqueous. But if it isn't, why isn't it mentioned in the literature? And so when I first came upon this, I immediately kind of doubted myself. You know, have we really been missing this all these years? Am I really missing it? Am I nuts? Or maybe I've really stumbled on something. Maybe I'm a genius. Well, to my chagrin, the answer is, and it came to me through my fellow Richard Jenkins, who about 3 days after we sort of really started uncovering this, came to me in his own quiet way, said, Dr. Koch, I found a paper that talks about posterior corneal astigmatism. I said, no. And about 2 days later, he said, I found a couple more. And I found a couple more. And he just kept piling papers on my desk. And really extraordinary number of papers that address this in one way or another, either imply it or document it. Here it is in Singaporean school children. Here it is in 3 to 5 year old children, Hong Kong children. Noel Alpin's implied it in one of his seminal papers. Here it is, another one, 1991, 1990, 1990, 1988, mention of Javal's rule. Javal's rule in 1890. Yes, 1890. Javal, unable to measure the posterior cornea, came up with a table in which you convert corneal astigmatism to ocular astigmatism, and you reduce it because of what he felt was against the rule astigmatism, and he surmised that it must be in the back surface of the cornea. Wonderful stuff, wonderful stuff. And by the way, I want to point out, I'm not the only person that's uncovered this. I know that Arturo Chayet has. Arturo and I have communicated about it since we both learned of our common interests. And I think others of you who have been kind of doing this now are starting to see it. Well, we've been doing a Toric IOL study, trying to understand this better, where we measured corneas preoperatively with anterior corneal measurements only, using the IOL Master Lenstar, Atlas, Manual Case, the Galilei SimK, or both anterior and posterior measurements with the Galilei. And we use the Holladay II calculator for this, because the Holladay II calculator is important because it takes into account the effect of anterior chamber depth and IOL power on the toricity, or the effect of toric power. So it's going to account for some of these other issues. And we have so far, I'm reporting on 33 eyes of 33 patients seen preoperatively and 3 weeks postoperatively. The axis of alignment of the IOL was measured, of course, intraoperatively, and then I personally measured it at 3 weeks follow-up, and we threw out any eye that was over 5 degrees off, so we'd have real tight numbers. And what I wanted to do was look at what I felt was the actual corneal astigmatism, which is basically whatever the astigmatism and the refraction is, minus the astigmatism that's calculated in the IOL from the Holladay II calculation. And then the prediction error would be the astigmatism that any given device measures minus the actual astigmatism. And I want to show this using double angle plots, just because I think it's convenient to group them this way. This is the sort of traditional single angle plot, which has laid out like we see it on the foreopter. It's very easy and comfortable to use with the with the rule eyes are here, but the against the rule eyes are clustered on one side and on the other. So a double angle plot takes the with the rule eyes and moves them around to the left, and it takes this group of against the rule eyes and rolls them around to the right. So now all the with the rule are grouped on the left and all the against the rule are on the right. So you're going to see this throughout my discussion of these results. So here's the prediction error with the IOL master. This is using the pre-op case. The IOL master said there was a half diopter more with the rule astigmatism than in fact there was in our calculations. Using the post-op case and taking into account my surgically induced astigmatism, again, a half diopter off. The against the rule eyes with the pre-op case were off again on the with the rule side, saying there's more with the rule astigmatism than actually was present by about 0.2, and then with the surgically induced astigmatism around 0.3. Really the same results with the lens star, 0.43, 0.54, and with the against the rule eyes around 0.25 or so. So if you calculate corneal astigmatism from measurements on the anterior corneal surface only, in the with the rule eyes, you're going to potentially get a mean overcorrection of a half diopter, and the against the rule eyes, you're going to get a mean undercorrection of 0.3 diopters. So, in fact, when we started this study, I had already kind of figured this out. So these eyes were in fact implanted with a preliminary version of the nomogram I'm going to present to you, and you can see that our results have improved dramatically. Here's the preoperative astigmatism for with the rule, and here's the pre-op and the against the rule eyes. And the actual results in these eyes is everybody's within a diopter, and most of them are within a half diopter. So it really tightens things down. Well, the story isn't complete because corneal astigmatism changes with age. So we need to account for this in our surgical planning. Now, where's the steep meridian on the anterior corneal surface at different ages? What happens to the front of the cornea as we get older? This is the percentage of eyes with the rule astigmatism, and that decreases over time. And concurrently, of course, the number of eyes who go against the rule increases proportionally. Personally, I've gone from astigmatism at 90 degrees to 180, and I've gone through all the oblique meridians, and that's what I think most of these obliques are. There certainly are some patients who clearly have oblique astigmatism that persists. What about the back surface of the cornea? Well, it's very different. The back surface of the cornea tends to stay steep throughout life. It doesn't seem to change. There's a little bit of increase in the eyes that develop steepness along the horizontal meridian, and a slight change in the obliques. So it's a different sort of situation. I'm going to show this kind of a different way, kind of graphically. This is again that double angle plot. So on your left will be with the rule astigmatism, and on the right will be against the rule. This will be the power. So the posterior cornea has this against the rule power, and this is the with the rule power in the anterior cornea. And let's follow it over time. There's the 20 to 29, not much change. 30 to 39, 40 to 49, not much change in the back. But look what's happening in the front, shifting against the rule, and the back is changing about 1/10 of a diopter. So we have a different pattern depending on whether you're looking at the front or the back. Well, what about the effect of age when you do clear corneal cataract surgery? Because we weaken the cornea with our corneal incisions, and maybe there isn't going to be as much of an against the rule shift. In a wonderful paper that Hayashi and colleagues published in the AJO looked at a group of patients who underwent surgery with 3 to 4.1 millimeter incisions. And then they had a non-surgery group, age-matched control, 153 eyes, followed for 10 years. Yep, 10 years, folks. Nobody does these kinds of studies. It's wonderful. And the question is, do sutureless wounds made temporally affect that drift? Amazingly, no, because they found about 0.37 diopters of against the rule shift over 10 years, same in the unoperated and the operated corneas. So when we think about our IOL calculations, I think we need to take this into account if we're going to extend the astigmatic benefit for our patients. So my final point is I think that we need a new nomogram for toric IOLs, and it will be a moving target as our measurements and our understanding improve. I wouldn't by any stretch say that what I'm going to present to you will be the final one that we'll end up with. Recommendation number 1 is to account for the against the rule shift with age. We need a new target for postoperative astigmatism, and that target should be slightly with the rule. And I know everybody's going to say, oh, you can't shift the against the rule to with the rule. They won't see. It won't affect them if they're not wearing glasses, and it won't affect them even with glasses as long as the overcorrection is less than a diopter. It just won't be an issue. And again, I would recommend using the Holladay II for these. Recommendation number 2, I think we need to account for posterior corneal astigmatism, that half diopter of against the rule astigmatism that is hidden in the with the rule corneas, and that 0.3 that's hidden in the against the rule corneas. And when feasible, I think we should try to measure these patients preoperatively. Our posterior corneal astigmatism measurements, I don't think they're perfect. They're getting better, and I think they're useful. And I think that intraoperatively now we're seeing some benefits of detecting this astigmatism by measuring the entire refractive power of the eye on the table after the lens has been removed, the crystalline lens. So I would propose as a starting point this, what I've called the Baylor Toric IOL Nomogram. And the with the rule astigmatism eyes, again remembering our target, a little bit of overcorrection. I'm not going to put a T3 in one of these patients until their with the rule astigmatism is 1.7 diopters. So I basically shifted the whole curve up by 0.7 diopters. Now, under 1.7, certainly one can use relaxing incisions to reduce it somewhat. But if you're remembering, you're factoring in the half diopter against the rule. On the back, you're factoring in the shift with age. Yeah, I think that this is a reasonable threshold. In contrast, I'm shifting the nomogram down 0.7 diopters in rule patients. So that the T4, for example, that you might put in somebody with 1.5 diopters of against the rule astigmatism, I'm going to put it in someone who has 0.8 diopters of against the rule astigmatism. And I'm even going to put a toric IOL 0.4 diopters of against the rule astigmatism, because you factor in the 0.3 of the back, a little overcorrection, those patients are going to do great immediately, and they're going to do great for many years, as opposed to leaving them potentially a diopter against the rule. Well, this needs more work. We need more data. We need to check accuracy. We need to look at the role of refraction in all of this, the role of age. Lots of factors to work through. And in closing, I want to just say something about Charlie. There's two wonderful pictures of him, one in the lab and one at the 25th anniversary of ASCRS by the Cavitron 6000. And those of you who've had the opportunity to read his really remarkable book, the last sentence in his book is, "But right now they're waiting for me in the operating room." Focused on the patients. Right now, our patients are waiting for us to solve these problems and provide them with the best possible vision for their lifetimes. I think the future is extremely promising. We've got a lot to be done, but we're up to this task. I'd like to acknowledge, first of all my colleagues here, all my colleagues at Baylor who've taught me so much, challenged me so much. I'm so grateful to know so many of you. My residents, fellows, and students who constantly ask me questions I don't know the answers to. It's really a wonderful experience teaching. Colleagues from industry who do so much to advance our field and are so important in the advances that we share in our industry. And especially ASCRS, it's been my society, it's taught me so much, it's been a way I've learned from all of you in ASCRS. It is the society of innovation, it's the society that has really brought us to where we are in this field of anterior segment surgery. And finally, my family, my son Malcolm, my granddaughter Violette. Violette heard part of this talk, and she'd heard it after she'd seen some videos, and once I got into this talk, she said, "Where are the eye pictures?" And especially my wife Marcia. I couldn't have had a more loving and devoted and supportive partner and wife. Thank you so much, sweetheart. Thank you very much.